So emerging therapies, this seems now to be a fruitful area since we really don't have good second-line treatments for this disease. So Dean, what are some of the targets that are now being pursued, and what are some of the trials that are being designed to support their use?
So let's start with the sequencing data. We did a study with everolimus a few years ago. We only had 2 out of 45 patients respond. Briskly. We were fortunate enough that our research team, led by Ira and Solid, looked at whole genome sequencing, and it was very interesting that this patient had both a TSC1 mutation and an NF2 mutation that made that patient's disease exquisitely sensitive to everolimus. And then in retrospect, if we looked at all the patients who had some degree of activity, they all had TSC1 mutations. So now, fast forward, we've been very fortunate that we have the TCGA in muscle-invasive disease and a number of other studies. And we've got a number of mutations that are novel and they're actionable. HER2, for example, in a small percentage of patients can be actionable, and that's under study with a number of different drugs, nationwide. FGFR3 is a big-time candidate for intervention. In the public domain, there are reported responses to blocking FGFR3. TSC1 is now being looked at, for example, in a basket trial. So right down the MAP kinase pathway, we're seeing that a number of different mutations are actionable and should be formally studied and are being formally studied right now. Unfortunately, we don't have our V600E equivalent right now for bladder cancer.
Right.
Hopefully we'll have it in a short period.
But certainly Jonathan Rosenberg from your institution is going to lead a study in CLGB. I guess it's going to be an intergroup trial looking at a very similar approach with that, trying to match the patients to their mutations.
Right, so it's proposed, it's called match-up, and you match up the drug to the actual mutation. I think it's a great design. It will lead us forward. I think we're going to be confronted with a couple issues, though. One issue is that if we take a look at the mutation rate in bladder cancer, it's very high. It's right up there with non-small cell lung cancer and melanoma. And so hopefully we'll be able to find those patients with a so-called quiet genome where targeting that mutation will work. But then I think what we're going to be also confronted with is patients who have multiple mutations that are actionable,
Exactly.
or multiple mutations, and which one is the most biologically active.
Right.
It's going to be a challenge, I think, for all of us.
Absolutely, and I think that's going to emphasize even more why we need to sequentially biopsy these patients in these trials, because what actually may be from the archival tissue may not be relevant to eventually what happens in the actual drug administration or the time they get the drug, and of course the drug can change that with selective factors.
Yeah. Even in the same biopsy, we've seen that in renal cell carcinoma, that you can get different mutations within the same tumor.
Mm-hmm.
So this is going to be very challenging for us. We're going to need liquid biopsies pretty soon in terms of being able to detect what is actually going on at that time.
And that's actually pretty commonly seen throughout some of the GU tumors. I mean, Ken Pienta published a number of years ago in his warm autopsy study with prostate cancer that even within the same organ, you would have different heterogeneous clones from the same disease with different genetic profiles. So this, I think, is going to be a very, very interesting area, and an area we may have to overcome with imaging or some other technique to detect these mutations. Evan, angiogenesis, does this play a role either in frontline or in second-line therapy?
Right. Well, it certainly has played a role in many cancers, but there also have been cancers where certain anti-angiogenic agents haven't worked. And so currently in bladder cancer, there is a trial ongoing with earlier introduction of bevacizumab, upfront therapy for metastatic disease. There is interesting data that's going to be coming out very soon using ramucirumab as well. And that is more in a second, third line setting in combination with docetaxel, but that seems to show a radiographic progression-free survival benefit in a randomized phase 2 trial with ramucirumab. So that being said and done, I'm very excited to participate and look forward to the phase 3 studies in that setting. But clearly, I think VEGF and VEGF receptors have an important role in regards to growth and spread of many different cancer types, and I think it makes sense in bladder cancer as well. So I'm hopeful that down the road we'll find a VEGF inhibitor that shows benefit.
Exactly, and I think in that respect as well, immune therapy. I mean, there is a relationship between angiogenesis and immune therapy as well. And Dean, what is some